morning, everyone. Am I audible, sir?
Yeah, Rohit, please go on.
Okay. Morning, everyone. So today's topic is just throwing a little light on the basics of arthroscope, the lens, light source, and the video system. So the arthroscope. This is the entire arthroscope. It comprises of the back part, the hind part, the mid part, and the fore part. The hind part comprises of the eyepiece, the light cable connector. There's a joint from where the back part gets converted to the mid part. Mid part is nothing but the shaft till the tip. The tip is has the lens, which has different degrees. There's a fiber optic sleeve and a protective outer sleeve towards it. The arthroscope comprises of multiple or comes in multiple degrees. It commonly comes in 0 degrees, 15, 30, 45, 70. But the most commonly ones are used are 30 and the 70 ones. It's nothing but an enlarged normal arthroscope is around 4 mm. That also comes in various sizes with a length of standard of 180 millimeters for the knee, which is autoclavable. This today's technology of arthroscope uses rod lenses instead of the conventional glass lenses. These are a few dimensions of the standard arthroscope that it comprises of and comes in. So this is what I was talking about. First, initially, the arthroscope used to be made out of conventional glass lenses. And what used to happen in this is you used to get a narrow vision. In today's arthroscopes, we have something called as a wide vision arthroscopes. So we don't have a circular arthroscope. It's kind of oblique and cut section. What happens because of this is we get a wider view and an overall better image quality. The only disadvantage that we have in this is now we don't use the 0 degrees, but other degrees is you have a blind spot in the center. So when you rotate, you get a 90-degree overall view in it, but there's a central blind spot. So rod lens is nothing but a special type of cylindrical lens that is highly polished on the circumference at both the ends. And this helps in increasing performance in an analogous manner. And it can help in shaping the beam and focusing it in a collinear manner. So it's something called as a Grin lens. So gradient index optics is nothing but converting and converging optical effects produced by a gradient of the refractive index into a material. So it helps in converging the lenses into a point source. So this helps in improving better visualization, better image quality, and better light output. Uh, like I said, there are two types of Hopkin lenses. Hopkins 1 and Hopkins 2. Today's arthroscope has Hopkins 2, which is a updated version of the Hopkins cylindrical lens itself. So I found this interesting study done by Meester in 96, where he compared optical catheter arthroscope with standard rigid lens arthroscope in 47 knees. And he stated that the rigid lens was way more superior and superior in autoclavability, image quality, and wide vision. The other thing about the arthroscope is your obturator and the sheath. Now, the sheath comprises of a small cylindrical tube, hollow tube, which is around 6.5 millimeters in diameter, which is more than the normal arthroscope lens. It has two outlets. One is on one outlet and one inlet for the inflow and the outflow, respectively. And in the center, there is a hollow for placement of the arthroscope or the obturator. On top, you can see the obturator, which is used to make the entry by putting it into the sheath and into the joint. So this is how it's normally connected. The power is connected to the light source, which is indirectly connected to the light source input on the hind part of the arthroscope. The mid part of the arthroscope is where you have your inflow, the sheath, inflow and the outflow tubings. The camera is connected to the TV monitor. And this is the basics of the arthroscope lens. Coming to the light source, The light source is basically comprises of two portions or two types. One is your cold light source, and the other is xenon light source. The cold light source does not produce heat emissions. Xenon produces heat emissions. It contains two electrodes that has a xenon gas in it. The cold light source is available in 150 watts, representing the minimum output necessary for adequate illumination. Our high output is potentially useful, however, provides a reserve function in case where additional light is needed. A xenon light source has a higher power output with a cooler temperature of 6000 kelvins, simulating daylight better than a cold light source. Xenon light sources should be used in cases where maximum color quality is required, but it produces heat. So that is the only disadvantage of a xenon light source. Similarly, there are two types of cables. One, you have your fiber optic cables, and one is the fluid cable. The fiber optic cables transmit light through bundled optical glass fibers, similar to the rod lenses, but they are not that rigid and are therefore very flexible. Bending the cable subjects the fibers to breaking. So after every use, slight amount of fibers break in the cable, thus decreasing the light intensity slowly over a period of time. Significant loss of the light transmission does not occur. However, until more than 50% of the fibers have been damaged, fiber breakage is not normal is a normal part of aging process, and the light cable should therefore be tested at regular intervals. These are autoclavable and come in a standard length of 150 to 180 centimeters. Longer cables are helpful in some situations, for like elbow arthroscope. Second thing is the fluid cables. Consist of plastic tubings filled with special fluid that conduct 40 to 50% more light efficiently than fiber optics, are less flexible. However, they are more difficult to handle, and they should be sterilized by immersing in a disinfectant solution rather than being autoclaved. This imparts somewhat natural appearance of the articular cartilage. This gives a bluish tinge to it rather than a soft warmer light. So this is how an image will look in a wear or in a used fiber optic cable versus a very brand new fiber optic cable. It's nicely, brilliantly illuminated compared to the used one because the fibers tend to break over a period of time with aging. This is another interesting study that I found that Sandhu did, where he gave some recommendations on how to avoid arthroscopic burns. So he made the recommendation saying that the light cable end must never be resting on the drapes once the light source has been switched on, because the thermal burns is a serious possibility. The light source should be switched on only after the light cable has been connected to the arthroscope. For maximum safety, the arthroscope and the cable light end should be placed in a kidney dish when not directly in use. A retractable shield of 2.5 centimeters fitted to the light cable end would virtually avoid the potential of a combustion. An alteration of the arthroscopic drape material may further reduce the risk of combustion. So these are the few recommendations that he gave to prevent thermal burns in arthroscopy. Coming to the video system, and so this is a normal video system trolley, which comprises of the monitor. A small secondary monitor is there sometimes, but not in most systems. You have the light source and the camera unit, the power unit, the pump unit, the printer, if at all, and the trolley and the base. Coming to the camera, initially it used to be a tube camera. Then it went on to becoming a one-chip camera. Today's cameras that we normally use are three-chip cameras. 4-chip, 4K, 8K, these advanced number of pixels, they go on increasing. But a standard high resolution camera is what is required. So tube camera is where nothing but first type of camera that was developed only in the days of video arthroscopy. These cameras supplied a brilliant image with an exceptional depth of field and excellent color reproduction. The disadvantage was that it was heavy, relatively large, and it had a tube system. These problems spurred the development of solid state chip cameras. So one chip camera is basically based on the semiconductor system. The color images are produced by covering the light sensitive components of the appropriate color filters. Image quality and color reproduction were somewhat poor initially, but improved significantly over a period of time. It provides better than 450 lines of resolution. The latest one-chip camera have programmable keys on the camera housing that can be used to control various camera functions or the functions of the peripheral devices at the touch of a finger. Today's cameras have a 3-chip equipped separately to detect and process each of the 3 primary colors, as blue, yellow, and green. Blue, yellow, and red. This arrangement provides an extremely high quality image with true to life color reproduction. The horizontal resolution exceeds 750 lines. In one chip, we had 450. So even the finest tissue distinction can be appreciated. Modern camera features digital automatic exposure light, digital color settings, and automatic white balance. A built-in digital image processor can further improve image quality, bringing out the structural designs by means of digital edge. So here you can see at the handpiece, you have these buttons. So in today's camera system, you have multiple buttons where you can record, where you can click photos, where you can stop recording, when you can pause recording, when you can have a picture-in-picture transmission. In this photo, you can see the top one is a single chip camera and the down one is a 3-chip camera. So what are the ideal requirements or how would you state an ideal camera should be? So the ideal camera should have an ergonomic design. It should have a mechanism for the coupling of to the scope, which can be a coupling mechanism or a J mechanism or anything. It should have something called a zoom lens, where you can, where it can allow you to zoom in on a particular object and zoom out. The sharpness should be adjustable. It should have built-in control functions, like I mentioned, picture-in-picture, recording, pausing, sending and saving to hard disk, etc., etc. Multiple functions are there. There should be a control unit and a camera cable, and the camera should be sterilized in a proper, better environment. So initially, these cameras were just sterilized by dipping in alcohol, but that over a period of time causes degradation of the outer covering and the image quality, the lens. So now in today's cameras, they are much more better and rigid to getting degraded. So that is an improvement in cameras. Monitor should be large enough to permit very fine structural details. The minimum recommendation is 20-inch screen, and it should be at the level of the surgeon's eye. Particularly throughout incremental contrast enhancement, the digital video system can significantly improve the visualization of the surface details. The data is filtered, two-dimensional, and weighted according to the specific target criteria. Weighting factors are selected to produce a marked accentuation of the visually perceived contrast and sharpness. A built-in microprocessor performs the approximate 50 million calculations per second that are required for this type of image processing. So it is nothing but converting your 2D images, your 3D images into a 2D one. This electronic contrast enhancement can significantly improve the visualization of edge contours and fine contours differences, especially during examination of homogeneous articular structures. A level 1 or level 2 contrast setting is recommended when a good arthroscope is used. Too much contrast makes the image appear overdrawn, marbleized, and unrealistic. The value of electronic enhancement is most apparent when an older dull scope is used. Combining a 3-chip camera with a digital arthroscope almost creates the impression of a 3-dimensional image, like I mentioned earlier. The latest generation of 1 and 3-chip cameras are now equipped with a digital image processor. So, like I said before, in this image quality, you can clearly distinct where your camera is focused, that is brilliantly illuminated. But the peripheral surrounding vision is also not too bright or not too out of focus. So it should be completely focusing on entire structure. It should outline the entire structural detail in today's world compared to the older cameras. Something called as a picture-in-picture, like I had mentioned before. It is nothing but a digital feature that can display 2 different images simultaneously on the monitor. It may be used, for example, to display images from the VCR, the CD player, the digital, or previously operations of previous findings alongside the current arthroscope, so that an accurate comparison can be made. This feature is particularly useful when transmitting images from operating room. In case this feature is used when basically you're having conferences or you're having live surgeries going on. A built-in zoom function is also available for today's camera. Thank you.
Rohit, you said
Yes, sir.
something like the cross section is not round but oval or oblong or something. What did you say?
Yes, sir. So initially the arthroscopes used to be like perfectly round in cross section. But that gave us a circular or a narrow viewing image. Today's arthroscopes are a little oblique, sir, in cross section, so that gives us a wide image. Also, they have an incorporated Hopkins lens. That's a cylindrical lens compared to the conventional glass lenses. So that gives a better image quality and a better image output, sir.
How does it go with the for obliquity? You didn't. I always emphasize on the for obliquity and rotating the lens.
Yes, sir.
And you didn't say much about it. I thought of only the for obliquity is the one which is oblong.
Okay,
and as you turn, you see different fields of the joint, and thereby your field of vision is enhanced.
Right, sir. Correct, sir. So in the center, you have something called as a blind spot, and depending on the angulation of your scope, when you go on rotating, your image goes on getting enhanced. That is true, sir. But what I was talking about is when you cut the arthroscope in cross section. So the older arthroscopes used to be perfectly circular. Today's arthroscopes are a little oblique. So when you're viewing through today's arthroscope, you will have a better and a wider image compared to conventional arthroscopes.
Okay, then when you come to theater, let's have a look at the lens.
Yes, sir.
But I would like to emphasize to the fellows that very often you just move the camera and try to see different areas of the joint. It is not so. It is you must turn the cable so that the for obliquity shifts or changes. So you see different parts of the
Yes, sir.
joint, and that's your steering wheel. Thank you.
Thank you, sir.
Rohit,
Also, David, Rohit did not mention that
Yes,
the connector to the light cord is mobile. You can, as you said, you turn the light cord, don't try to turn the arthroscope. If you turn the light cord, the camera will automatically turn with it, or the lens will turn with it. So the original arthroscopes did not have a rotating light cord. They had a fixed light cord connection. They had a straight end-on telescope. But as the Hopkins system was introduced, rod lenses and obliquity was introduced. And the workhorse is a 30-degree arthroscope, as you mentioned. But 70 is used quite often in the shoulder.
Yeah, that's right. We all persist a 70 and even a 0 because the companies recommended. So you have all the three, you won't know when you need it. And 0 was never used. And 70 we used to use in the posterior compartment very often to see the ramp lesion or PCL and all that. But now with a better technology, a better maneuverability and technique, even 70 is not necessary.
So I also
And
found
also,
out this. Sorry.
You need to
Yes,
remember that we have 1.8 millimeter arthroscopes that can be used in the wrist and in the thumb, and the 2.4 can be used in the ankle and in the wrist joint.
Yes, sir. I also found out this one interesting thing. Carl Stoss is coming up with a scope, in which there's just one scope lens where you can adjust intraoperatively from 0 degrees to 90 degrees. I don't know how effective that scope or how good that scope will be, sir. But you, with a flick of a button, you can change the viewing angle from 0 to 90, however you want it in one scope.
Rohit,
It may be true, Rohit, but now we have to keep our costs down.
Okay.
I'm sure such a lens will be very costly,
Yes, sir.
and we have to depend on the skill of our hands
Right, sir.
and not costly equipments.
Yes, sir. Correct.
Carl Stores gave this as demo a couple of couple of years back, I think. We had it for
Uh-huh.
about 2 months.
Okay. Okay, sir.
It has a knob. If you turn the knob, the angle will change.
Right, sir. Right, sir.
So, but it's quite expensive, not
Okay.
for having this change in angle. So it's already there in the market.
Okay, sir.
And other recent advances, there are cameras and scope systems which are coming up wireless. No wires attached to them. No light cables, no video cables. Wi-Fi enabled camera systems. So a small storage device within the camera, light source
Yes.
also within the camera. So probably that will be the future. Technology-wise, it's not very complicated. Only thing storage device, battery powered, something like a drill gun, where without cables, something like that, where you have a big battery. If you have a lightweight battery system, that will be the future. It was already demonstrated in AAOS, I think. Muniz had actually shared that in one of the groups. So we can get information from him if you're interested. So that's one recent advance. And this talk is a basic talk where you need to be aware of the tower, the picture which you showed, no? Tower. Can you show
Yes,
that?
sir. Yeah. Yes. Yes.
You go into the OT, our technicians keep everything ready over there. But if you see them preparing before the case, you would be aware how much of mix and matching they need to do based on the case which is there, based on the surgeon. So based on that, the tower structure changes minimally. You might not notice it, but you need to be there before the case starts to know how it is planned. So this also is a part of your learning. Even though everything is ready, it's not fixed. It has to be changed based on what camera system you use and based on um, the light source and camera must be matching. The light source depending on the company when you have multiple systems. But for you, if you're a traveling surgeon going around or you're operating in some other unit which is not yours, you need to be aware of all of these so that before you start or during a procedure, you're not stuck. And during timeout, all of these parts and whether it's working has to be checked. These are all certain small things which we don't notice them in our daily practice here because it goes as a routine. But as a learning process, you need to be aware of the intricacies involved in this. Thank you.
So can I stop sharing, sir?
Yeah, Rohit. Thank you.
Thank you. Thank you, sir. Thank you.
Good morning, sir. Good morning, sir. Am I audible?
Yeah, Shikor, good morning.
So, continuing with the topics of basics of arthroscopy, I'll be presenting today's topic on shavers and RF. Most of my literature is taken from the textbook of Strobel. Starting off with shavers, starting off with the component overview, we have one control unit, that is the main box that controls multiple functions, which I'll be going through in detail later on. It has a connecting cable that connects the power or the driver into the handpiece, which is seen in the bottom right figure. The handpiece will have different attachments to it depending on the function it is designed or desired to carry it out. It depends on the blades that we attach and the suction tubing. These are the two attachments that go into the handpiece. Starting with the components in detail, we have the control unit, which is this setup box, which has multiple functions. Mainly, it decides or it enables us to opt for an optimum drive type. Now, there are two drive types, that is a flexible cable drive and electric drive. The flexible cable drive is nothing but where the control unit contains a motor that drives the torque or the turning capacity to the handpiece, which turns the shaver blade through a flexible drive shaft. Now, electric drive is where the electric power only is transmitted by the cable from the control unit to the handpiece. And the handpiece houses the motor that turns the shaver blade, that is the inner tube. It has other features like the display, which shows us the drive mode. Drive mode is indicative of whether it is rotating clockwise, counterclockwise, or in oscillating mode. It shows the rotations per minute or the speed at which the blade is rotating. It has the memory. For example, different blades or burr attachments have different memory setup. For example, if you want the burr to be attached, you do not have to manually change the speed. The burr will automatically, once it is sensed in the control unit, the speed will automatically change. The RPM will change from 2000 for a shaver blade to 4000 to 6000 for a burr. It also shows the rotation speed in terms of the maximum and the minimum capacity of that machine. Another component is the foot pedal, as you can see here. It is another mode of input where the surgeon or the operator can change the drive modes, whether he wants clockwise, counterclockwise, or oscillating. It can also change the speed at which the shaver rotates. This is the cable I was talking about, the electrical cable, which transfers the electric current into the handpiece, which houses the motor that turns the shaver blade. Now, the connecting cable is this blue lengthy connecting cord, and it depends on the type of handpiece also, depending on the different companies. Regarding the connecting cable, in handpieces with a built-in electric motor, the connecting cable delivers the electric current from the control unit to the handpiece. If the motor inside the control unit, the drive torque is transmitted to the handpiece through a flexible drive shaft. Now, as you can imagine, if it is a flexible drive shaft mechanism, it is very cumbersome and it is very difficult to do a high precision work when the entire shaft mechanism is that flexible metal tube compared to just an electric cord. So handling in this case will be particularly imprecise when small joint attachments or a small joint or pediatric cases or adults in cases have to be operated upon. So the new ones are coming up with only the electrical connecting cable where the motor is housed inside the shaver blade, the handpiece. Coming to the handpiece, as Dr. Rohit has already mentioned, when operating with this in the hand, it has to be functionally oriented with an ergonomic design. And most importantly, it has to be lightweight to avoid operator fatigue and loss of precision. These are the newer handpieces that are coming in. Now, how do we grip the handpiece? There are two modes of gripping. One is the pencil grip and the other is a handshake or a pan holding grip. Now, according to Strobel, it also depends on the position of the operating surgeon, whether he prefers to stand and operate or sit and operate. In case of sitting and operating, the operator should hold the shaver like a pen, whereas if standing, the operator should use a pan handle or a handshake type of grip. Now, the advantage of pen holding, it allows for a greater precision and it also allows for perceiving and responding to the tissue resistance encountered by the instrument tip. We can, by the tactile feedback, if the substance that we are encountering is hard, soft, synovium, bony, all these feedbacks that we can get with a pen holding grip. Now, what are the different blades? There are, according to the function that we want them to carry out. For example, removing the synovium or a fat pad, we want serrated blades. If you want to remove a bony osteophyte, you want a burr-like spherical with a ridge serrations. You want sharp edge or serrated edge. So there are different options we can mix and match depending on the function we want them to carry out. So it gives a lot of maneuverability and options that we can use intra-op. So it depends on the type of blades, and the speed determines the function of the shaver. And it is two types, disposable and non-disposable. There are many factors that determine the function of the shaver blade. One is the rotations per minute. That's the RPM. As you can see, this is a 4000 RPM. This is controlled with a foot pedal, or in some cases, the handpiece itself has the RPM setting available in-house. Now this might seem counterintuitive, but then hard tissue is better cut using higher RPM, whereas softer tissue is better cut using a lower RPM. Now the reason is, you can compare this to a filling of a heart. If you're going into tachycardia, or the heart is beating more than 200 per minute, then the filling capacity of the heart is compromised. So the adequate blood filling is going to be low and non-functional. Similarly, if the shaver blade is rotating too fast, the tissue that gets trapped inside the shaver blade and gets cut will be ineffective or inadequate. So as it spins faster and faster, it becomes less and less efficient. For most application, a blade spinning at approximately 2000 RPM is more efficient than a blade spinning at 4000 RPMs. RPM of 4000 to 8000 are used in case of burrs, or burring bony projections, or osteophytes, or notchplasties. Under no circumstance is speeds higher than 8000 to be used, because it creates small bone fragments that could adhere to the synovium and be very difficult to remove. Now, another factor that determines the function of the shaver blade is the size of the cutting window. This I've taken from a literature that was comparing between the different sizes of the cutting window. Cutting window is basically the opening that is present in the outer sleeve. Now, the rotating mechanism is the mechanism of the inner sleeve, or the shaver mechanism. It's a tube in tube. So the outer sleeve has this opening that is called the window. The larger the window in the outer tube of the shaver, the more efficiently the soft tissues is drawn into the window and cut by the rotating inner blade. Smaller windows limit the amount of tissue cut per cycle, and the resection is not as deep as with a larger window. Small window, the use we primarily can use it for partial synovectomy in the anterior part of the knee. A large window shaver can be used for resecting portions of the fat pad. Now, other factors that determine the function is shape of the cutting window. It depends on the type of tissue that is desired to be cut. Side cutting windows with sharp edges are preferred for the removal of meniscal tissue. For best cutting action, the sides or edges of the window are beveled inwards so that it traps the tissue within the window, and the rotating shaver blade will finally incise it or cut it off. The oval windows with a side or side and end cutting configuration are used for the removal of soft tissues. By contrast, if you look at the attachment to cut the bone, if you look at burrs, it doesn't have a window per se. What it has is a false window. That is basically a sheath, so that the rotating spherical ridged burr will face only towards the bone that is desired to be cut or shaved off. The remaining part of the burr is shielded, or more likely the surrounding soft tissue is protected against the burr. That is the function of the window in cases of burrs. Another factor is the shape of the cutting blade. If it is serrated, which is more effective in handling soft tissues, or if it is smooth. Now, frequency of usage and reusability. Reusable blades must be routinely checked for dulling, as dull blades will tear rather than incise and will result in traumatic surgeries and cause intra-op bleeding that can cloud the field of view. Single-use blades, as you can see here, are sharp on initial use but cannot be sterilized because of the plastic adapters. They're good for single-use surgeries alone, but it can be expensive. Now, what are the different types of blades and the blades that we commonly use? One is a synovial resector. That is the most common for resecting the synovial tissue. It has an oval window with a smooth inner blade. It can also be used for large cartilage fibrillations, which have to be removed. Meniscus cutter is used for resecting meniscal tissue. It has a rectangular window and an angled tip for a side and end cutting action. Now, the third one is an abrader or a spherical burr. It is enclosed in an outer tube with a large oval window, which is a false window or a protective sheath. It is used to remove osteophytes or other bony structures, smoothing the inlet of bone tunnels and performing notchplasties or acromioplasties. Now, certain complications that we commonly see, one of which is clogging of the shaver blade, which can be due to multiple reasons, probably by drawing in too large tissue fragments into the cutter, if the suction is too slow, if there is disproportion between the instrument diameter and the size of the cutting window, and constantly pressing the shaver against the tissue to be removed. Now, if you constantly press the window against the synovium or the tissue that is planned for removal, there is no fluid that is going to flush the cut materials through the tube into the suction drainage. This reduces the flow velocity in the lumen of the blade and promotes rapid clogging by tissue fragments. So if you face such a complication, what can you do about it? One is check your working technique. The best technique, as per Strobel, is to touch the tissue to be resected. And after the shaving is done, retract the tip so that adequate fluid can flow through the blade lumen along with the tissue fragments to be removed. This flushes the lumen of the inner rotating blade clear, allowing additional tissue fragments to be removed during the next pass. Adequate suction. Weak suction leads to repeated clogging of the blade as there is no enough force to flush out the fragments from the tubing. Maintain sufficient inflow. One mechanism is using a pump that is advantageous for maintaining a sufficient fluid outflow. The newer pumps are either volume dependent or pressure dependent. So we can set the pressure we want the intraarticular fluid to be, and if the higher the pressure, the outflow can also be maintained at high pressure to maintain the fluid filling in the joint. The last is using an oscillating mode. Oscillating rotation of the inner blade helps reduce the risk of clogging. Coming to an RF. So basic principle is that biological tissue has varying concentrations of electrolytes, and using this, an electric current has multiple effects on living tissue, some of which are thermal effect, where it creates heat, Faraday effect, where it stimulates the neurons and the muscle cells, and electrolytic effect, where ion shift is there, which is also found to be damaging to tissues. Faraday effect is basically stimulation of electrically responsive cells and is avoided by use of high frequency alternating currents. The effect is negligible in frequencies more than 300 kilohertz, and that is the function at which we commonly use to avoid inadvertent damage to the surrounding tissues. Electrolytic effect also can be avoided by using similarly high frequency alternating currents. Now, there are two modes in an RF. That is the coagulation mode, where it dries the tissue while producing larger amount of heat. And there is a cutting mode, where it divides or removes tissue by generating heat over a punctate or a broader tissue. Temperature parameters used routinely that we see is more than 40 degrees Celsius, it creates a reversible cell damage. More than 49, the damage is irreversible. 70 degrees is where you coagulate the tissue by conversion of collagen into glucose. 100 degrees is where the intra and extracellular water changes to vapor. This is normally where we start the cutting mechanism. And 200 degrees Celsius, the tissues get charred. Now, cutting with electrocautery, the principle is basically the electric current creates a rapid series of mini explosion. High frequency electric current divides the tissue by heating the cellular fluid to more than 100 degrees Celsius, as we discussed in the previous slide, so rapidly that there is no time for the tissue water to vaporize slowly. So it creates a high vapor pressure that is created that explosively disrupts the tissue and cells, thereby cutting it or incising it. Also, the vapor pressure helps in insulating the active electrode. Function of electrocoagulation mainly helps by achieving hemostasis by stopping active bleeding. Thermal coagulation occurs when the current slowly heats the water in the intra and extracellular tissues fluids to a temperature of approximately 70 degrees Celsius. That is when the collagen is converted to glucose and helps dehydrate or dry out the tissues that is actively bleeding. Selective tissue denaturation and hemostasis is achieved. Then there are two modes of frequency voltage that is used for electrocoagulation. One is unmodulated high frequency voltage. That is the soft, it is also called the soft coagulation mode, and it is recommended for situations in which the monopolar coagulation electrode is placed in direct contact with the tissue. Advantage is that it is less traumatizing to the tissues than coagulation with modulated high frequency voltage. Modulated high frequency voltage or forced coagulation is a high voltage more than 500 volts to induce arcing between active electrode and the tissue, thereby increasing the depth of coagulation, not only the surface tissue but also the deeper tissues, and it is associated with damage to deeper tissue layers due to, so it is not commonly used. Now the design is similar to that of the shaver. It has a control unit where we can designate the frequency of the voltage and the strength of the electrocoagulation or the cutting mechanism. It has a handpiece and multiple attachments. The attachments that we use depend on the function that we opt to achieve. It has a different setup for different functions. We have the hook electrodes, which is seen in 4.5, 5, 1.5 mm. We have the ball tip electrodes, that is 4 and 2.5 mm. And we have the needle electrodes. The electrodes are disposable, and if used more than once, each and every electrode must be checked to confirm that its insulation is still intact. If the insulation is damaged, a new attachment should be used, since faulty insulation can damage the surrounding skin or soft tissue or surrounding cartilage when we use it intraarticularly. So coming to the advantages of the RF and the electrodes, it is comparatively small in size. The hook electrodes are approximately same size as that of an arthroscopic probe. Thus, it can perform the dual function of acting as an electrode as well as a probe, thus requiring no more space, extra space than a probe, which is useful in very tight spaces like the posterior horn medial meniscus or without touching the surrounding structures like the articular cartilage. There is no dulling. Cutting is performed with disposable hook, and needle electrodes, which are not subject to dulling, are used. Mechanical cutting instruments tend to dull with prolonged usage and needs to be changed frequently. But then there is no dulling mechanism seen in this RF electrodes. The third is minimal postoperative bleeding. So in these cases, small blood vessels are carefully and precisely cauterized during cutting, and therefore the risk of postoperative and intraoperative bleeding creating clouded space is greatly reduced. Next is selective hemostasis. Small hemorrhages caused by mechanical instruments can be selectively coagulated with electrocautery. Bleeding after a synovial biopsy, partial meniscectomy, or other procedures done without a tourniquet can selectively be coagulated under vision, as well as bleeding points in the lateral retinaculum following a lateral release can also be coagulated. It can also be used on bony surfaces following a resection of bone or a notchplasty or acromioplasty. Port is more of a double-edged sword. It has high malleability. So in this case, what we see is that if an intra-articular lesion can't be reached with a straight electrode passed through the standard instrument portal, the shaft of the electrode can be bent slightly to facilitate passage. But then the opposite edge is that in cases of bulky patients or obese patients, if it is difficult to go through the soft tissue, the malleability will also counteract our entry, because the more force we apply, the more the chances of the electrodes being bent and disfigured. Fewer instrument changes. Like I said, the hook probe, for example, it acts as a probe as well as an electrode. So compared to using an instrument like a punch or a basket forceps, which requires intermittent withdrawal to reassess the cut surface and to probe the cut margins, in case of an electrode, once the cut or coagulation mechanism is turned off, the electrode itself can be used as a probe to visualize and assess the stability of the cut margins. Multi-directional cutting. The cautery knife can cut in any direction desired, forward, backward, right, or left. When cutting current is switched on. All we need is to turn the electrode facing towards the tissue that we desire to be cut. Now, some disadvantages that we have faced while using an RF is the formation of bubbles. Because it actively turns the surrounding fluid into vapor, bubble formation is a common factor that we've encountered. Small air bubbles can be formed during cutting of meniscal tissue or coagulation of blood vessels, obscuring vision that needs to be intermittently suctioned from the field. Iatrogenic cartilage damage. Like I mentioned before, if the insulation is not checked in reusable electrodes, or there can be inadvertent touching of surrounding cartilage with the hook electrode that can damage the cartilage when the coagulation current is on, especially if the insulation is defective. Accidental cartilage lesions during meniscectomy may involve the submeniscal part of the tibial plateau or the posterior surface of the femur. But most commonly, what we see is that these cartilage damage are less commonly found in the weight bearing and more commonly in the non-weight bearing compared to mechanical instruments. Short circuiting. Now, this is rare, but it has been documented in certain literature as per Strobel. It says that there is a possibility, there have been documented cases where the RF has automatically turned on without the surgeon activating the RF, and it has caused tissue damage intra-articularly in the past. So if the surgeon must change the joint position or otherwise turn his attention from the surgical site, he is always advised to remove the electrode from the joint and then continue. Skin burns. Now, the next complication is when you use the RF for a prolonged period of time and you take it out of the joint and place it somewhere close to the leg. There is a possibility that the RF can cause skin burns, or if the RF is placed next to the leg and by mistake someone activates it, it can cause skin burns to the operative limb, which has to be we have to be very careful about, especially in this day and age. Then there is a monitor interference, again, an old complication, rarely seen nowadays. If the camera and monitor are not adequately shielded against radio interference, the electrosurgical equipment may cause loss of picture when the current is switched on. Picture problems can also result from damage to the electrosurgical instrument cable and camera cable. Muscle contraction. When we do performing surgeries like lateral release and clearing out the field very close to the muscle margins, especially the vastus lateralis and the medialis, we have to pay extra attention, or we have to be extra cautious regarding the tissue damage that is done to the surrounding muscles, because it can cause inadvertent acute hemorrhage and subsequently scar formation that can be particularly troublesome if it involves either of the vasti. Thus, electrocautery should be used very carefully and only in short bursts when cutting in close proximity to the muscle. Some of the main indications that we use the RF for is meniscal resection. Almost all types of meniscal cuts can be done accurately with an electrocautery knife. Lysis of adhesions. I had the opportunity to assist in 2 cases where there was extreme stiffness because of fibrous tissue in the joints, where the shaver alone was ineffective. We had to go in with electrocautery, and it helped a great deal in lysing the adhesions or scar tissue and the fibrocartilaginous tissue that was found within the joint. And cutting current is switched on at a high power setting, dividing the adhesions. Lateral release. Lateral reticulum should be incised very carefully using the coagulation mode, especially to deepen the zone of necrosis. The division proceeds in layers, while the vessels coursing in the lateral retinaculum are exposed and preserved if possible, and only the collagenous portion of the retinaculum is divided. Plica resection. Selective hemostasis. Bleeding sites observed after a peripheral meniscal resection or partial synovectomy can be selectively coagulated with a hook electrode. The hook is placed against the bleeding vessel and the coagulation current is briefly activated. And it can also be used to achieve hemostasis when performing notchplasty or osteophyte removal or acromioplasties, where the bone ends begin to bleed and clouds the vision. Resection of scar tissue. Scar tissue also in the intercondylar notch or in the olecranon fossa can be belted down with the ball-tipped electrode. The hook electrode can also be used to remove or dissect scar tissue from the bone surfaces. And it helps in the removal of fixed intra-articular bodies. Last is the cartilage debridement. where especially in modified outer bridge grade 1 and 2, the fibrillations or the softened area can be debrided or cleared off using the RF in a coagulation setup. And last is shrinking of ligament structures. Exposure to high temperatures causes the shrinking of collagen fibers. This shortening effect depends on the temperature, duration of exposure, type of electric current, water, electrolyte content of the collagen, and type of electrode. So to revise, we went through the shavers and the RF. We've studied the components like the control unit, the cables that attaches, the shavers, and the type of electrodes that goes into the RF. We've studied the working principle of both the shavers and the RF and the indications for their respective usage, and studied the advantages and disadvantages. Majority of my sources were taken from the book of Strobel, sir. Thank you.
Thank you, Ashik. It was in detail, nothing much to add. But again, this is a basic talk. You must be aware of the basic mechanism behind each equipment, how it performs.
Yes, sir.
And shaver blade, I'm not sure I missed it. The types of opening and what tissue, what type of blades to be used.
Yes, sir. There are serrated edges. For example, they have outer sleeve, which determines the window. The larger window can be used for trapping in more soft tissues like the fat pad. Smaller window for partial synovectomy like surgeries. And we've got edges of the blades, which can be serrated, which are better in dealing with synovium and the fat pads. We've got smooth edge that can be used for fibrillations of the cartilage. Then also we've got the, in cases of meniscectomy, we want the window to be end cutting and side cutting, whereas in other functions, we use only side cutting. In case of burrs, the window, it's a false window, which protects the surrounding tissue from the burr. These are the different types of blades and windows and the blades, sir.
So you must be aware of them, and you might not be able to have all of them in your armamentarium. So
Yes,
maybe 2 or 3 would be helpful, where you have one aggressive one, which is the serrated one,
yes,
one
sir.
with a larger window, one with a smaller window. Choosing them for those situations would be ideal. That's what we have here. And a
Yes, sir.
larger blade and a smaller blade. So it depends on the company. What is the size of a smaller blade? I mean, the width of the blade. Some are 3.5, some are
Yes, sir.
0.5. So all of that you must be aware and use them, being aware of these factors.
Yes, sir.
To add here, sir, your point, sir.
No, you didn't tell us, Ashik, who invented this. Lanny Johnson.
Yes, sir.
And Gopal should know him personally. Lanny Johnson's one, and he invented this in his workshop, in his garage. And then it was fine-tuned by Smith & Nephew and then the other companies. And that made all the difference with the shaver.
Yes, sir.
In performing arthroscopic surgery. And in the early stages, I still remember his talk, he used to say, you got to be very careful. Otherwise, your blade will work like a chondro plow. You know, sometimes you see being used by beginners, the entire cartilage will get plowed through.
Yes, sir.
You know, so you got to be very careful and use it when you do a cadaver and see how it's being done.
Yes, sir.
And we never use a serrated blade for a meniscus area.
Yes,
You've got
sir.
to have a much simpler one. In the same manner, the radio frequency also, you have to be very careful and where you use. And it was, multi-directional instability was diagnosed as very popular long back. And once they got that radio frequency, a lot of surgeons went in and did a radio frequency shrinking.
Yes, sir.
Simply, cooked the tissue there. And it became smaller.
Yes, sir. Shrinkage. Yes.
Only to get torn in after some time. And a lot of patients used to undergo grafting from other tissues to contain the head of the humerus in position. So I always think that radio frequency should not be used for bleeding surfaces. You want the bleeding so that healing will take place. So all the equipments are very helpful, useful. You must know them, when to use, how to use, and how not to damage any normal tissue.
Yes, sir.
Got to be very careful. Thank you.
Yes. Thank you, sir.
So Gopal, you remember, is Gopal still there?
Yes, I am.
Hello.
The Lanny
Yes, I
Johnson.
Yes, I spent some time with Lanny Johnson, and I was there when he first introduced his intra-articular shaver system, IAS, as we used to call it. We just had three things. We had a straight cutter, an angulated one, and a burr. Subsequently, that the disposable ones were introduced. Yeah, I was there in Lanny Johnson's lab as well as in the operating room with him.
Okay. Thank you, Gopal. Thank you.
Thank you.
Sir, is my screen visible? Sir, is my screen visible?
Yes, Arjun.
I welcome everyone to today's plastic talk. I'll be talking about aseptic loosening in TKA. So I'll be discussing some registry data. I'll be defining aseptic loosening. I'll be describing the causes of failure, what is osteolysis, its pathogenesis, how to diagnose, a radiographic criteria, and the principles of revision. So this is data from National Joint Registry of 2021. Aseptic loosening accounts for the largest numbers of revision cases, especially single stage. And if you see the number of revision cases that are done globally, the infection accounts for the cause, the most common cause for early revision, and aseptic loosening accounts for the is the cause for late revision in TKA. So aseptic loosening, it refers to failure of joint processes without the presence of infection. It is often associated with osteolysis and an inflammatory response within the joint. So the causes of failure, it's often multifactorial. There can be malalignment of the processes, high BMI, small tibial components, polyethylene wear, osteolysis, all lead to aseptic loosening. So it can be broadly classified as implant factors, surgical factors, and patient factors. Implant factors being fixation type, implant design, use of constraints, and wear debris from metal, cement, or polyethylene. And surgical factors like joint malalignment and ligamentous imbalance, surgical and cementing technique. Patient factors being osteoporosis, stress shielding, and high BMI. So let's discuss about tibial component loosening. Malalignment and malposition is the leading cause for total knee loosening, and it accounts for 9% of the total cases. Loosening rates for modern processes are low, and not all processes which are positioned in varus go for loosening. Also, the use of metal back tibial components that we are using now has further reduced the incidence of tibial loosening. Mulal et al. Identified that polyethylene wear is now regarded as a late mode of failure that occurs usually after 11 years from day of surgery. So this is a study which was published in 2018, which discussed the radiostereometric analysis of migration in TKA implants. If you notice, the maximal tibial point motion is for the first 6 months, the acceptable range is less than 0.5 mm. If it is more than 0.5 mm, the chances of loosening is more. After 6 months, it goes for a stabilization. So some migration is there. It happens in the first year, and then it tends to stabilize, and the direction of the migration of the tibial tray tends to be medial, posterior, and downward. The migration was greater for unsymmetric process. and cement penetration of 2 to 3 mm is ideal for adequate interlock to prevent aseptic loosening. So about femur component loosening. Loosening a femoral component, it is uncommon, whether it is cemented or uncemented. But when it occurs, it follows a pattern in which the posterior bone resorbs, allowing the femoral component to go into flexion. About patellar loosening is often associated with patellar fractures or dissociation of the polyethylene and metal bag components. What we now commonly use is all polyethylene component, and the loosening of the cemented all polyethylene patella is infrequent. The incidence of component loosening is about 1%, but it has been reported to be as high as 3%. And loosening is more common with all designs with small central lug. And what we use, the patella has got a tripod configuration with 3 small peripheral lugs, which is popular now. So Mason et al. Reported that among 577 tripod configuration, he noticed no loose patella components at average of 3 years. This is a study which was published in the Journal of Orthopedic Surgery and Research in 2023, where they brought out that if we use patella components of size larger than 38 mm, there is high chance for revision than smaller buttons. In the study, they noted a patella component loosening of 3.3% at midterm follow-up. So what is osteolysis? Osteolysis is an inflammatory response to particulate debris. So regarding the pathogenesis, the steps can be divided into particulate debris formation, macrophage activated osteolysis, processes micromotion, particulate debris dissemination. So particulate debris formation, it comes from the wear, and types of wear can be adhesive wear, abrasive wear, third body wear, volumetric wear, and linear wear. Volumetric wear is the main determinant of number of particles created. Adhesive wear, microscopically, the polyethylene sticks to the processes and the debris gets pulled off. Abrasive wear is due to the cheese grater effect of processes scraping of particles. Third body wear, when there are additional particles in the joint space, like cement particles, etc. Linear wear, it's measured by distance the process has penetrated into the liner. So all these wear particles activate the macrophages. This leads to macrophage recruitment and increases TNF-alpha expression, increases rank expression. So there is rank ligand mediated bone resorption, and it results in osteolysis. So the third step is processes micromotion. When there is osteolysis, surrounding the processes, it leads to micromotion. The micromotion leads to increased particle wear and further prosthetic loosening. N-telopeptide urine level is regarded as a marker for bone turnover and is elevated in osteolysis. And because of the inflammatory response, the hydrostatic pressure will be increased. This leads to further dissemination of debris into the joint space. Now, why does TK has greater wear and less osteolysis when compared to THA? Ng et al. Have described 4 factors for that, because in TKA, the type of wear is due to delamination and abrasion. So these produces larger fragments of polyethylene. Usually only the smaller fragments will be able to induce the macrophage activation. Second, the synovial cavity of knee is extensive. So it has a greater capacity to engulf and digest wear debris. So knee is inherently more resistant to osteolysis when compared to hip. Third, the fixation interface between the PMMA is better sealed in TKA when compared to THA. Fourth, the shear and tensile strength on PMMA is less at the knee than at the hip. So the decreased amount of stress and fatigue means decreased fracture of the cement mantle. So which leads to decreased access for debris to the bone cement interface. So the chances for fracture of cement mantle is more with THA due to the shear and tensile strengths on the PMMA. What are the factors affecting wear rate of polyethylene TK? One is higher activity level, modularity, that is motion between the modular tibial insert and the metal tray, the type of sterilization and the type of manufacturing. Older polyethylene component had more osteolysis. And the thickness of the insert also accounts for wear particles. Less than 6 mm thickness, there is more stress component producing more wear. The presence of third body wear debris, tibial modularity, the design of tibial post, malalignment, everything contributes to wear particles, formation of wear particles. So moving forward to diagnosis. In well-fixed component, there can be osteolysis, but it can be asymptomatic. In some cases, they can present as bogey synovitis. There will be tenderness, which is localized to tissues around the loose component, and the aggravating factors in pain will be usually weight-bearing and activity-related. In some cases, instability can be even present, but presence of clinical malalignment is pathognomic. The lab test, the ESR, CRP are essential. This has to be normal, and excluding infection is very critical. Regarding the radiographic criteria, a radiolucent line that is wide, that is greater than 2 mm, or progressively enlarging cement bone or metal cement lucent line is indicative. Component migration is pathognomic. Collapse of underlying trabecular bone with subsidence of the component, cement fractures, and changes in the degree of knee angulation on weight-bearing views are the other findings suggestive of aseptic loosening. So a loosened line of 1 to 2 mm between cement and bone is considered normal, and it can occur due to cement contraction. When a loosened line progressively widens, that is when we have to think about aseptic loosening. And tibial tray is most commonly involved than the femoral component. A full-length hip to knee ankle film is very essential because it allows accurate assessment and it can diagnose distant osseous problems, which might be contributing to the pain of the patient. This is a classification brought out by the Scuderi group. It's a modern knee society radiographic evaluation system. It's a descriptive classification than predictive or prognostic classification. The loosened lines are documented as partial or complete with respect to zone. So the idea was to update the radiographic assessment and evaluation system and to bring about uniformity in documentation. So as per this classification, if you look at in the X-ray, the tibial component, AP view, if there is osteolysis in zone 1, zone 1 is osteolysis under medial base plate. Zone 2 is osteolysis under lateral tibial base plate. Zone 3 is osteolysis under central keel. Zone 4 is osteolysis with adjacent to the stum extension. Zone 5 is inferior aspect of the tibial keel or stum. Again, this can be similarly classified in the lateral view of the tibial tray. Zone 1 is the lysis under anterior base plate. Zone 2 is lysis under posterior tibial plate. Zone 3 is lysis along the central keel. Zone 4 is the lysis along the revision TK stum extension. Zone 5 is inferior aspect of the tibial keel or stum. The femoral component also, the osteolysis can be mentioned in the AP view and the lateral view. Zone 1 is osteolysis under anterior flange. Zone 2 is under adjacent to the posterior flange. Zone 3 is along the central box. Zone 4 is along the stum extension. So this can be classified in AP X-ray and lateral X-ray of the femoral component. So others investigation, CT and MRI viable options for assessing larger osteolytic lesion to aid in preoperative planning. Technetium bonds can be done, but the most accurate test for diagnosis of aseptic loosening in TK is SPECT or CT arthrography. Treatment. Non-operative or observation can be done. Non-operative treatment or observation can be done when there's a stable implant with minimal symptoms. Medical management with bisphosphonates is an option. For revision TK, the indication is pain due to aseptic loosening, evidence of osteolysis that would compromise the revision in future. So if you are going for revision, the previous surgery details, the implant used, its size and company should be collected at all cost. So this is a publication which came in 2017, where they brought out algorithm for management of wear and osteolysis after total knee arthroplasty. As per the algorithm, patient is asymptomatic, minimal osteolysis, regular follow-up has to be done. The patient is symptomatic, there is progressive osteolysis, and the implant is properly fixed, well-fixed implant. Then isolated polyethylene exchange with bone grafting can be done. But what we commonly see is component malposition, and in such cases, revision TKR has to be done. Polyethylene exchange for wear and osteolysis and moderate success in medium term, but should be avoided in cases of accelerated wear. So principles of revision TK. The principles includes the identification of the mechanism of failure, meticulous preoperative planning, adequate exposure, extraction of the component with minimal bone loss, bone defect management, joint restoration and selection of appropriate revision component, obtain ligamentous and joint stability with adequate flexion and extension balancing. And rehabilitation of the patient is also very important. So surgical technique. The techniques to enhance exposure in revision are cordyceps snip, VY cordyceps plasty, tibial tubercle osteotomy, medial epicondylar osteotomy. This is how a cordyceps snip is done. The medial arthrotomy is extended proximally and laterally at an oblique angle. So this produces an enhanced exposure. This is how a VY cordyceps plasty is done. The medial arthrotomy and oblique incision is extended laterally and distally, forming an inverted V. So the exposure is obtained by a turn down of the advancing the patellar tendon distally. Next option is a tibial tubercle osteotomy. This picture demonstrates how the location of the osteotomy. The tibial tubercle is osteotomized and is rotated laterally. One thing that has to be made sure is that the lateral drill holes are proximal to the medial drill holes, pulling the tuberosity distally. Another option is the medial epicondylar osteotomy if exposure is needed to the posterior femoral condyle and posterior tibial condyle, in which the medial epicondyle is osteotomized and reflected with tissue attached to the epicondyle. So joint line restoration is very important in revision TKA. Joint line elevation of more than 4 mm is associated with patellofemoral problems. Joint line elevation of more than 8 mm is unfavorable, produces unfavorable outcome, even in revision TKA. And studies show that if the joint line is elevated more than 5 mm, itself produces poor outcomes. Many joint line references are there. One is medial joint line comes distal 30 mm distal to medial femoral condyle, like that 27 mm distal to lateral femoral condyle, one finger below the inferior pole of patella, one finger above the head of fibula, 12 to 16 mm distal to the femoral attachment of PCL. Then old meniscal scar, if present, it's very much reliable. Then the adductor tubercle joint line. But among all these, adductor ratio, which is the ratio between the adductor tubercle joint line distance and the femoral width, is the most accurate method of reconstructing the joint line. It produces a constant value of 0.52 with no variation with sex. So it's very important that the joint line has to be reconstructed in revision TKA. Basically, it is a 3-step approach: recreate the tibia, recreate the femur, rebuild the flexion space, and recreate the extension space. So regarding recreating the tibial platform, first establish the tibial platform on which the subsequent arthroplasty is built. So this is very important because it affects the knee in both extension and flexion. A flat surface that is perpendicular to the mechanical axis must be created. Augmentation can be done to recreate the proximal tibia close to the original height of the tibia as far as possible. So this will provide the surgeon with more option for choosing appropriate polyethylene insert to balance flexion and extension gaps. So this is a pictorial demonstration of how the reconstruction of tibial component is done. Modular augments comes in wedges, blocks, or structural allograft can be used. In knees with severe tibial bone loss, modular tibial cones or sleeves can be used to reconstruct the proximal end of tibia. And when the tibia is reconstructed, we have to make sure that proper rotation, the component is positioned in proper rotation using the tibial tubercle and anteromedial aspect of tibia as reference points. These are images of one of our own cases where we did revision. You can see the trabecular cone and the stumped implant and how we have positioned the tibial component. So next is recreate the femur. The correct size of the femoral component has to be chosen because it specifically influences the flexion space by restoring the anteroposterior dimension and the posterior condylar offset of the femur. So another useful preoperative step is to template the opposite side to obtain a relative idea of the size. Also, always look at the size of the femoral component that is being removed and whether it is appropriate. In a revision scenario, there will be posterior bone loss will be occur. So intraoperatively, if we template, we run the risk of undersizing the femoral component. The epicondylar width of the femur can also be helpful in selecting the appropriate femoral size. There's a danger in selecting an excessively small femoral component is that it can fail to restore the posterior femoral offset, and it will compromise the flexion stability. So it is better to select a larger femoral component and augment the posterior condyle to restore the anteroposterior dimension. And in remission scenario, as I said before, bone loss is usually more significant in the posterior femoral condyle area, but anterior femoral bone loss can also occur, and it can also influence sizing. So can also influence sizing. Femoral component rotation has to be vital to restore the knee kinematics and patellar tracking. The best way to determine the rotation is based on the epicondylar axis. To ensure the femoral component rotation, the posterolateral condyle generally has to be augmented. If a PS or similar process is used, intercondylar notch is prepared at 90 degrees to the epicondylar axis. In cases of severe bone loss, epicondyles may not be available. In such a case, the reference for femoral component rotation should be done with knees at 90 degree of flexion, and the tibial platform can be used. So the key step is to recreate the joint line and adductor tubercle joint line distance. The adductor ratio can be used. Other landmarks, as I said, are the joint line is 25 mm from the lateral epicondyle, 30 mm from the medial epicondyle, and joint line of a prosthetic knee of average size is 30 mm from both epicondyles. This is how augmentation, this is a pictorial representation of how augmentation is done. If there is symmetrical distal femoral, if there is symmetrical bone loss, or if the joint line has been previously elevated in the index procedure, then symmetrical distal femoral augments can be used. For asymmetrical femoral bone loss, asymmetrical augmentation can be used. The distance from epicondyle to the posterior condyle also should be maintained as here. So this is the images of the same patient where we use the sent implant, sent femoral component to recreate the femur. Once the femur is recreated, we have to rebuild the flexion space. Balance of the flexion space has to be balanced first. So this step requires choosing the correct tibial polyethylene articulation. So with the provisional femoral component in place, the thickest tibial polyethylene surface that fills the flexion space is inserted on the provisional tibial tray. This is a constrained insert. This is the images of the same patient that I discussed before. Next is rebuild the extension space. Rebuild the extension space. The knee has to be brought into extension with the tibial insert in place. If the knee can be fully extended and the gaps are equal and stable, the polyethylene insert is correctly sized and femoral augments can be finalized. But when an imbalance in flexion and extension gaps present, additional adjustments are required. So this is the final image of this same patient who underwent revision recently in our hospital. So take-home points from my presentation is that the most common cause for early revision in TK is infection. The most common cause of late revision in TK is aseptic loosening. The causes of aseptic loosening is multifactorial. In addition to osteolysis, osteolysis is rare with recent polyethylene. In revision scenario, the joint line has to be restored. Adductor ratio is reliable for joint line restoration. And when we are balancing the gap, the flexion gap has to be balanced first in a revision scenario. Thank you.
Arjun, good presentation about aseptic loosening and highlights about the revision totally arthroplasty. But considering this aseptic loosening is one of the challenging scenario for the surgeon, as well as very difficult to explain to the patient, and the scenario that it's very difficult to explain to the patient when the patient is coming with pain with the early onset of hello, Arjun, am I audible?
Yes, sir. Yes, sir. You are audible, sir.
Yeah, the aseptic loosening and infection is the two scenario. It's very difficult to differentiate clinically, especially in the patient presenting with and especially in the midterm follow-up. For example, if it's a patient is presenting at 2 years with knee pain unexplained knee pain with effusion. But the only thing is with aseptic loosening, did you undergo any paper in a recent publication from Journal of Arthroplasty? That was published in Jan 2023. It is a very good paper in basic science, and they have identified certain radiological changes which could indicate the early sign of aseptic loosening. But in the early loosening is very difficult to identify radiologically, unless otherwise if you have a gross osteolysis, if you have a gross malpositioning of the component. So in those scenario, is there any other additional findings in the X-ray, Arjun?
So radiolucent line, the thickness of the radiolucent line can be, if it is progressive, the thickness of radiolucent line, if it is progressively increasing in follow-up, then it can be suggestive.
No, what I'm asking is, Arjun, you see the radiolucent lines, it won't be appear in all the cases.
Yes, sir.
Suppose the patient have a well-fixed implant, but still if you're suspecting a aseptic loosening due to a polywear or because of the cement disease, we don't know. So
Yes,
in those situations, is there any other additional radiographic finding so that you can easily pick it up? Okay, this case is a sign of aseptic loosening, not a sign of infection, because even a CRP, the paper has come out, CRP is not a good indicator for infection, chronic subtle infection.
Yes,
That's
sir.
what the recent publications also says. So we have to more vigilant in identifying whether this case is for a chronic subtle infection or aseptic loosening. And there are a few things which they mentioned in that paper is the patient with subtle aseptic loosening, they do have changes in the lateral view, especially you have to look into the anterior portion of the tibial base plate. There will be a anterior heterotropic bone formation.
Okay, sir.
Especially in the lateral view.
Okay.
Can you get that point? There will
Yes,
be a
sir, understood, sir.
heterotropic bone
Understood.
formation.
Heterotropic,
So
okay.
that is a heterotropic bone formation. That indicates there is some micromotion is happening in that particular place, so that there will be reactive bone formation which is happening. So that is a one radiological finding they come out with to identify there is no gross varus malpositioning, there is no gross osteolysis, but the patient, they do come with some unexplained knee pain. In the X-ray, if you pick it up, there is a heterotropic bone formation. So that case can go for a late failure or because of aseptic loosening. That is not a signs of infection, because they can compared with the two groups. One group is with the infective group, another group they selected with a strict selection criteria with the aseptic loosening. So,
Okay.
but the infective group, they didn't show any typical bone form. They showed multiple other findings in infective group, but in not a particular finding, especially in the heterotropic bone formation. Number one. Number two, in the AP view, they showed there is a large cyst formation, especially in the medial tibial base plate and between the cement and bone area.
Okay, sir.
So these are the two important radiological findings they proposed. This could be an early finding or the patient presenting without any gross malformations or gross malalignment in the radiological finding, and the patient presenting with aseptic loosening. So these two things are newly come up with plain radiographic findings. So otherwise you can do a SPECT or bone scans to identify is there any loosening or any uptake because of infection. So the simple radiographic finding, these two things you have to look in the follow-up. Yeah, that is very important, number one. And number two, unless otherwise, if you know the concrete evidence that this case is for aseptic loosening, you can attempt for a single stage revision, but provided you should know what is the reason for the failure, number one. Number two, you should able to identify this is the particular reason for a failure of this case. So revision is the one scenario, you should know the reason for failure. So without knowing the failure, just by in a simple, okay, this is aseptic loosening, if you go ahead, then you'll be in trouble. So always you have to identify what is the cause for the failure and good preoperative planning, number two. Number three, okay, this is not the case of infection, then you can plan for a single stage revision, either isolated tibial component or revising both the components with exchange of body. So that you have to plan preoperatively, that is very important. And pathomechanism, you explained very well how the macrophages, they will react to the foreign body, especially when there is a cement or polywear, how it happens. That is very important, especially in the total knee, because the total knee, we do large numbers, and we do expect a large number of revisions in the total knee arthroplasty. But certain factors you have to make sure that you should avoid that could be the reason for the late failure, because you have mentioned that there are various reasons for the failure, especially the surgical factors, patient factors, implant factors. So all these things, the certain things which can be preventable and it can be modified, you should take care. Those things you should take care, so that the patient should not land up in a late revisions or in the midterm follow-up revisions. That is very important. And number two, in the revision aspect, the basic principles you have mentioned, and now I'm not going into the details of those things, but you have to differentiate in the OPD whether this is an infection or aseptic loosening. And you can do in the OP procedure, you can go for a very well aspiration of the knee. And another important things you didn't mention in the presentation, in the aseptic loosening, you should not forget there could be a reason for the metallosis, or the patient can develop because of high level of the metals being released from the implants. It could be a nickel induced or cobalt chromium induced metallosis or osteolysis. So that is one of the reason. So that's why now the newer implants has come up with a lot of modifications in the composition biomaterials, so that they could reduce the post-surgery elevation of the metals. And in one interesting study they come out recently, they compared the two groups, especially the patient using a cobalt chromium alloy, and they used the oxynium alloy. And in both the groups, they found there is an elevation of the nickel metal. And surprisingly, the surgeon want to analyze what could be the reason. Even with a nickel-free implant, nickel was elevated. And they found that the most common reason for elevation of the nickel in the post-op is using the saw blade and the metal zig. Because all these things, suppose if you're using the saw blade, we usually use a 1.27 mm. Suppose if you're using 1.33, the thick saw blade, or when a tight fit is zig, the cutting slot, so that can create a lot of metal debris inside while cutting the bone saw. So that has caused a lot of elevation in the post-surgery elevation of the nickel. So always when you're using the zig or instruments, you should be very careful. You should not create a lot of metal debris. That is very important. That is a very interesting study. Yeah. So otherwise, this is a very important topic. You should know how to handle it and how to identify. And you should identify the causative factor. And in the revision scenario, you should identify whether an isolated revision or combined revision. Accordingly, I had to prepare. Yeah. Thank you.
Thank you, sir.
Thank you.
Raj, I have a question for you. What about the Mako knees? Do they help in avoiding malalignment and subsequent problems such as aseptic loosening? Does the Mako technique improve the alignment?
So that's what they come up with. One group from Australian group, they come out with different phenotypes to identify. Because
Yes.
our gold standard is we have to restore this neutral mechanical alignment. But still there is an outliers, and there is a unhappy knee of around 10%. And on those patients, they identified whether these patients, they could have underwent a kinematic realignment or anatomical realignment, so this, and they can avoid this late failure or early revision. But definitely the robotics, now they come up with a concept of kinematic alignment. But only thing is we have to wait and see, sir, and how this outcome is going to be. But till now, our gold standard mechanical neutral alignment, 95 to 98%, they do very well if you follow all the basic principles during a primary.
I will let you know if I live long enough. I have a Mako knee.
Yes. Yes, sir. Definitely, sir.
Thank you. Excellent presentations. I'll
Thank you,
say
sir.
goodbye.
Thank you, sir. Thank you.
Goodbye.
Good night, sir. Sir, it's 8:30, so shall we end the meeting, sir? Nice discussion, Dr. Viren.
Thank you. Thank you, Sanjay.
Good night, everyone. Good night, Santosh.
Nice.
Baby doing all right?
Yeah, all well.
Okay. Very good.